Pleural effusion involves the buildup of fluid in the pleural cavity, which is the space between the parietal and the visceral layers of the pleura. This condition can develop independently or as a consequence of adjacent parenchymal diseases, such as infections, malignancy, or inflammatory disorders. Pleural effusion stands as a significant contributor to pulmonary-related mortality and morbidity. A 65-year-old male patient presents to the clinic with a 2-week history of progressive shortness of breath and left-sided chest pain that worsens with deep breaths. He has a history of congested heart failure and hypertension. On physical examination, his blood pressure is 145/90, heart rate 98, respiratory rate 22, and an oxygen saturation of 92%. Auscultation of the chest reveals decreased breath sounds and dullness to percussion at the base of the left lung. Chest X-ray shows a blunted choleophrenic angle on the left side. Which of the following is the most likely diagnosis? Pneumonia, PE, pleural effusion, lung cancer, or tuberculosis? The correct answer is pleural effusion. The patient's presentation of shortness of breath, chest pain that worsens with inspiration, and a history of congestive heart failure is highly suggestive of a pleural effusion. This is further supported by physical exam findings of decreased breath sounds and dullness of percussion at the lung base, which are the classic signs of pleural effusion. The chest X-ray finding of a blunted choleophrenic angle is also a characteristic of pleural effusion. While other options like pneumonia, PE, lung cancer, and TB can present with similar symptoms, the combination of a clinical history, physical examinations, and imaging results in this case is the most consistent with pleural effusion, likely secondary to congestive heart failure. Approach to pleural effusion includes differentiating if the pleural effusion is transudative or exudative. In the US, the three most common causes of pleural effusion are heart failure, pneumonia, and malignancy. The normal pleural space typically contains about 10 ml of fluid, which is the delicate equilibrium maintained by two key factors, the hydrostatic and oncotic pressures in the visceral and parietal pleural capillaries, and the continuous drainage by the sulcal lymphatics. When this balance is disrupted, pleural effusions can occur. The presence of pleural effusion is indicative of an underlying medical condition, which may be related to either pulmonary or non-pulmonary origins. These conditions can either be acute or chronic. Although the causes of pleural effusions are varied, the majority are attributed to a few common conditions: CHF, pneumonia, malignancy, or PE. In a healthy adult, the pleural cavity normally contains only a small amount of fluid serving as a lubricant between the two pleural surfaces. The fluid is from the blood vessels of the parietal pleura and is reabsorbed by the lymphatics located in the dependent areas of the diaphragmatic and mediastinal surfaces of the parietal pleura. The driving force for the movement of interstitial fluid into the pleural space is hydrostatic pressure from the systemic vessels supplying the parietal pleura, resulting in pleural fluid has a lower protein content compared to serum. Excess fluid accumulation in the pleural cavity can arise from either an increase in production, a decrease in absorption, or a combination of both, disrupting the normal balance. When pleural effusion is predominantly due to elevated hydrostatic pressure, it is typically classified as transudative. Conversely, increased permeability of mesothelial cells and capillaries or impaired lymphatic drainage generally leads to the formation of exudates. A patient with pleural effusion may show no symptoms or experience exertional breathlessness, which depends on the extent to which the effusion restricts the thoracic movement. In cases of active pleural inflammation, known as pleurisy, the patient often experiences sharp, intense pain that is localized and fluctuates in intensity when the patient is breathing or coughing. The physical examination findings for pleural effusion can often be subtle. In cases of a large effusion, one may notice fullness in the intercostal space and dullness upon percussion on the affected side. Auscultation typically reveals decreased breath sounds, along with reduced tactile and vocal fremitus. Notably, egophony is most pronounced at the upper part of the effusion. During active pleurisy, without the presence of an effusion, pleural rubs may be audible and can sometimes be mistaken for coarse crackles. When a patient presents with findings of pleural effusion, diagnostic imaging is recommended. A chest X-ray is often the first test to evaluate the possible pleural effusion. Trace radiographs are a valuable tool in confirming the presence of a pleural effusion. The radiographic appearance of an effusion varies depending on its volume. On an upright PA chest view, at least 200 ml of fluid is typically required to obscure the choleophrenic angle, a finding known as the meniscus sign of pleural effusion. Conversely, in the lateral chest view, as little as 50 ml of fluid may be detected with this sign. Chest ultrasound is more sensitive than a plain radiograph and is highly useful for diagnosing pleural effusion. It also plays a critical role in guiding thoracentesis, a procedure for fluid removal from the pleural space. Thoracentesis is recommended for all cases of unilateral effusion in adults, not only to ascertain the cause of the pleural fluid, but also to alleviate the patient's symptoms and aid in recovery. Again, once pleural effusion is suggestive, thoracentesis is the next diagnostic test. Pleural effusions can be broadly categorized into two types, transudates and exudates, differentiated by their underlying mechanisms of formation and chemical composition of the pleural fluid. Transudates are typically caused by an imbalance in hydrostatic and oncotic pressures, whereas exudates arise from inflammatory processes affecting the pleura or impaired lymphatic drainage. It is noteworthy that in certain instances, pleural fluid may display characteristics that are a mix of both transudate and exudate. Leit's criteria is a high-yield criteria to memorize and remember before you take your exam. Leit's criteria is used to identify if the pleural effusion is transudative or exudative effusion. If any one of the following criteria is met, the fluid is an exudate. All three must be met for the fluid to be a transudate. Pleural protein over serum protein over zero point 0.5, pleural LDH over serum LDH over zero point 0.6, and pleural LDH over two-thirds the upper limit of normal for serum LDH. A 63-year-old male with history of hypertension presents to the emergency department with a 10-day history of left-sided chest pain and progressive shortness of breath. He denies fever, cough, or weight loss. On physical examination, his blood pressure is 140 over 85, heart rate 90, respiratory rate 22. Auscultation reveals decreased breath sounds and dullness of percussion at the base of the left lung. A chest X-ray shows a left-sided pleural effusion. Thoracentesis is performed, yielding a pleural fluid with the following findings. Pleural fluid protein over serum protein ratio of zero point 0.6, pleural fluid lactate dehydrogenase 200, and a serum LDH of 180. According to the Leit's criteria, which of the following is the most accurate classification of this pleural effusion? Is it a transudative, exudative, cannot be determined, chylous, or hemothorax? The correct answer is exudative pleural effusion. According to the Leit's criteria, a pleural effusion is classified as exudative if it meets at least one of the following Leit's criteria. The pleural fluid protein over serum protein ratio of greater than zero point 0.6, the pleural fluid LDH over serum LDH greater than zero point 0.6, the pleural fluid LDH is more than two-thirds of the upper limit normal for the serum LDH. In this patient's case, the pleural fluid protein over serum protein ratio is zero point 0.6, which meets the first criteria for exudative effusion. Therefore, despite the pleural fluid LDH not exceeding the serum LDH or two-thirds the upper limit of normal, the effusion is classified as exudative. This classification suggests that the effusion is likely due to a local affecting the pleura, such as infection, malignancy, or inflammation, rather than a systemic condition that typically leads to a transudative effusions such as heart failure or cirrhosis. Transudative pleural effusions primarily occur due to an imbalance in oncotic and hydrostatic pressures. Causes of transudates include heart failure due to an elevated hydrostatic pressure, hypoalbuminemia from cirrhosis or nephrotic syndrome due to reduced oncotic pressure, and pulmonary embolism. Exudative effusion is due to an inflammatory process. The two most common causes of exudative effusions are pneumonia and malignancy. But also think about tuberculosis, Dressler syndrome, pancreatitis, and PE. A 70-year-old man with a history of CKD presents to the emergency department with 1 week history of increasing shortness of breath and bilateral leg swelling associated with orthopnea. He denies chest pain, cough, or fever. On PE, his blood pressure 160 over 90, heart rate 102, and respiratory at 24. Bilateral pitting edema up to the knee is noted. Auscultation of the lungs revealed decreased breath sounds at the bases bilaterally with dullness to percussion. A chest X-ray shows bilateral pleural effusions. A BNP is elevated. Which of the following is the most likely cause of his pleural effusions? Nephrotic syndrome, CHF, liver cirrhosis, malignancy, or PE? The correct answer is B, CHF. The patient's presentation of bilateral pleural effusions with associated symptoms of shortness of breath, leg swelling, and an elevated BNP strongly suggests CHF as an underlying cause. CHF can lead to fluid overload and hydrostatic pressure changes, resulting in transudative pleural effusions. While nephrotic syndrome, liver cirrhosis, malignancy, and PE can also cause pleural effusions, the clinical picture of fluid overload, evidenced by bilateral edema and effusions, as well as orthopnea, along with an elevated BNP, is most consistent with CHF. When dealing with questions on pleural effusion, look for associated findings. This can help identify the cause of the pleural effusion. For instance, if the patient presents with pleural effusion and has bilateral leg edema, consider heart failure, cirrhosis, or nephrotic syndrome. If the patient presents with S3 gallop and elevated JVP, consider heart failure. If the patient presents with a unilateral swelling and tenderness, acute dyspnea, tachycardia, consider pulmonary embolism. If the patient presents with pleural effusion with ascites, consider cirrhosis. Certain pleural fluid appearance is useful to suspect the cause of the pleural effusion. A milky fluid suggests a calithorax, resulting most often from lymphatic obstruction by malignancy or thoracic duct injury by trauma or surgical procedure. A purulent fluid indicates empyema, and cultures of the pleural fluid must be obtained as the next best step. Grossly bloody fluid may result from trauma, malignancy, post-pericardiotomy syndrome, or asbestos-related effusion, and indicates the need for a spun hematocrit test of the sample. A pleural fluid hematocrit level of more than 50% of the peripheral hematocrit level defines hemothorax, which often requires tube thoracostomy and high-yield question on your exam. Another high-yield content to remember is the pleural fluid cell count with differentials. In cases where an exudative pleural effusion is clinically suspected or confirmed through a laboratory chemistry test, it is advisable to submit the pleural fluid for comprehensive analysis. This should include total and differential cell counts, Grand stain, and culture to identify any infectious agents. Additionally, cytological examination of the fluid is crucial to assess for the presence of abnormal cells that may indicate underlying conditions such as malignancy. Remember, WBC of more than 1,000 suggests exudative. WBC more than 10,000 suggests peripneumotic effusion, and WBC of more than 100,000 suggests empyema. Neutrophil predominance suggests infection, such as pneumonia or PE. Lymphocytes of more than 50% are considered lymphocytic predominance, and the common conditions include tuberculosis or malignancy. If the patient presents with a lymphocytic predominance and TB is part of the differential diagnosis, adenosine deaminase ADA is an enzyme that is ordered and is elevated in tuberculous pleural effusion. Eosinophils of more than 10% suggest either a drug reaction or a parasitic infection. Amylase suggests pancreatitis or esophageal rupture. Pleural fluid pH of less than 7.2 suggests complicated effusion, and the next best step is always a chest tube. A low pleural fluid glucose of less than 60 is associated with specific conditions. For instance, a low pleural fluid glucose may be due to increased glucose utilization in the pleural space, and you think of bacterial infection or malignancy, or a low pleural fluid glucose may also be due to a decreased transport into the pleural space. Think rheumatoid pleurisy. A high pleural fluid triglyceride of more than 110 suggests calithorax, which results from a disruption of the thoracic duct that occurs from trauma or thoracic surgery. As far as pleural fluid cultures are concerned, in community-acquired pneumonia with pleural effusion, the most common organisms are Strep pneumoniae, Strep pyogenes, Staph aureus, or Strep anginosus. In hospital-acquired pneumonia with pleural effusion, the most common organisms are Staph aureus and Enterobacteriaceae. A 55-year-old woman with a history of breast cancer treated with mastectomy 5 years ago presents to the emergency department complaining of shortness of breath and a dry cough for the past 3 months. She denies any fever or chest pain. On physical examination, her blood pressure is 130/85, heart rate 100, and respiratory rate of 20. She has decreased breath sounds and dullness of percussion at the right lung base. A chest X-ray reveals a large right-sided pleural effusion. Thoracentesis yields a fluid with a high protein content and a high number of lymphocytes. Which of the following is the most likely cause of her pleural effusion? CHF, bacterial pneumonia, tuberculosis, malignancy, or PE? The correct answer is D, malignancy. This patient's history of breast cancer, along with a new presentation of unilateral pleural effusion with lymphocytic predominance and a high protein content, strongly suggest a malignant pleural effusion. Malignant pleural effusions are commonly associated with lung and breast cancers and characterized by exudated fluid, often with a high lymphocyte count. Congestive heart failure typically causes bilateral effusions that are more transudative in nature. Bacterial pneumonia and tuberculosis can cause exudative effusions, but her lack of fever and other systemic symptoms makes these diagnoses less likely. Pulmonary embolism could potentially cause pleural effusion, but is less consistent with her clinical presentation and effusion characteristics. A pleural effusion associated with bacterial pneumonia is a peripneumonic effusion. It can be uncomplicated or complicated. Uncomplicated peripneumonic effusion is sterile or free-flowing effusion. Primary treatment is IV antibiotics for the bacterial infection and will not require any procedures. Complicated peripneumonic effusion is infected or loculated effusion. It's generally related to a pleural fluid pH of less than 7.2 and a pleural fluid glucose of less than 60. It requires thoracostomy tube drainage plus antibiotics. Empyema is a bacterial infection of the pleural space, resulting in purulent fluid or a positive Gram stain. Management always includes drainage, thoracic surgical consultation for thoracoscopic or open debridement and drainage is recommended if the effusion is refractory to antibiotics and drainage. A 72-year-old man with a history of COPD presents to the clinic complaining of increasing dyspnea and a productive cough over the past month. He also reports a recent weight loss of 10 pounds. On physical exam, he's tachypnic with a respiratory rate of 24. Auscultation of the chest reveals decreased breath sounds and dullness to percussion at the base of the right lung. A chest x-ray shows a right-sided pleural effusion. Thoracentesis yields a yellow fluid with low glucose content, WBC 10,000 with predominance of neutrophils. Which of the following is the most likely cause of his pleural effusion? TB, pneumonic effusion, CHF, malignancy, or PE? The correct answer is B, pneumonic effusion. The patient's presentation of increasing dyspnea, productive cough, and the finding of a neutrophil predominant low glucose pleural effusion suggests a pneumonic effusion, which is associated with bacterial pneumonia. This type of fusion is typically an exudate, high neutrophil count, and especially in the early stages of the infection. While TB, CHF, malignancy, and PE can all cause pleural effusions, the clinical picture and the fluid analysis in this case are most consistent with a pneumonic effusion secondary to bacterial pneumonia. A 66-year-old male patient with history of COPD presents to the ER with 4-day history of high fever, productive cough with greenish sputum, and an increasing left-sided chest pain. He also reports shortness of breath. On examination, his temperature is 101.5 Fahrenheit, blood pressure 130 over 85, heart rate 110, and respiratory rate of 28. Physical examination reveals decreased breath sounds and dullness to percussion over the left lower lung field. A chest x-ray confirms left-sided consolidation and a moderate pleural effusion. Thoracentesis yields purulent pleural fluid with a pH of 7.1, glucose of 30, and LDH of 1000. Which of the following best describes this patient's pleural effusion? Transudative, uncomplicated peripneumonic effusion, complicated peripneumonic effusion, malignancy effusion, or tuberculous effusion. The correct answer is complicated peripneumonic effusion. This patient's clinical presentation is suggestive of a pneumonia with an associated pleural effusion. The pleural fluid characteristics of low pH, low glucose, and high LDH, along with its purulent nature, are indicative of a complicated peripneumonic effusion. Complicated peripneumonic effusions are associated with bacterial pneumonia and require more aggressive treatment, often including drainage and sometimes intrapleural fibrinolytics, or surgery due to the potential for developing an empyema. This is in contrast to uncomplicated pneumonic effusions, which are typically sterile and resolved with appropriate antibiotic therapy for the underlying pneumonia. The pleural fluids findings in this case are not consistent with transudative effusions, which are usually due to systemic conditions like heart failure or liver cirrhosis, malignant effusions, or tuberculosis effusions. The indications for a chest tube insertion in patients with pleural effusion is very high yield on your exam, and they include empyema, positive pleural effusion culture, a patient with complicated pneumonic infusion, or using combination of intrapleural fibrinolytics and mucolytic agents, which has been shown to reduce the size of the effusion and reduce rates of surgical referral. Intrapleural fibrinolytics that you need to know include streptokinase, urokinase, and TPA, and mucolytic agent that you need to know is deoxyribonuclease, also called DNase. Another high yield key point that you need to know is the management of malignant pleural effusion. If a patient presents with pleural effusion on the same side as a lung nodule, order a thoracentesis. A positive cytology for non-small cell carcinoma established the malignancy as stage 4 lung cancer. If the pleural fluid cytology is negative on the initial sampling, repeat the thoracentesis and obtain a second sampling of the pleural fluid cytology. Remember, pleural fluid cytology sensitivity is about 65% on the initial sample, and if a second sample is obtained, additional 27% are identified. A 65-year-old man with a 40-pack-year smoking history presents to the clinic with complaints of shortness of breath and a persistent cough for the past 2 months. His physical examination reveals a decreased breath sounds and dullness of percussion at the base of the right lung. A chest x-ray demonstrates a right-sided pleural effusion. Thoracentesis is performed, and the pleural fluid analysis is exudative in nature. The most appropriate next step in the management of this patient is start broad-spectrum antibiotics, perform a pleural biopsy, order cytology of the pleural fluid, initiate treatments with diuretics, or schedule a bronchoscopy. The answer is C. Order cytology of the pleural fluid. The patient's history of long-term smoking and the presentation of an exudated pleural effusions are concerning for malignancy, particularly lung cancer. Cytological examination of the pleural fluid can be highly valuable in diagnosing malignant effusions. In cases where lung cancer is suspected, pleural fluid cytology is a less invasive method compared to a biopsy to confirm the diagnosis. If the cytology is negative and suspicion remains high, another thoracentesis is performed to obtain a second cytology before ordering a pleural biopsy or bronchoscopy, which are more invasive. Antibiotics are indicated in cases of suspected infectious etiology. Diuretics are used in heart failure related effusions, and pleural biopsy is more invasive and usually reserved for cases where cytology and other investigations are inconclusive. Now let's do some rapid fire questions. What are the three most common causes of pleural effusions in the US? Heart failure, pneumonia, and malignancy. What is the initial diagnostic test to evaluate a suspected pleural effusion? Chest x-ray. Which diagnostic imaging is more sensitive than a chest x-ray and plays a significant role in guiding thoracentesis? Chest ultrasound. What is the minimum volume of pleural fluid required to obscure the costophrenic angle on a chest x-ray? At least 200 ml of pleural fluid. This type of pleural effusion is caused by an imbalance in hydrostatic and oncotic pressures. What is it called? Transudative effusion. What type of pleural effusion arises from inflammatory processes affecting the pleura or impaired lymphatic drainage? Exudative pleural effusion. This type of pleural effusion requires only one of the Leist criteria for diagnosis. What is it? Exudative pleural effusion. What are the two most common causes of exudative pleural effusion? Pneumonia and malignancy. Which pulmonary disease is associated with both transudative and exudative pleural effusions? Pulmonary embolism. What are the three causes of pleural effusion associated with bilateral leg edema? Heart failure, cirrhosis, and nephrotic syndrome. What is the cause of pleural effusion associated with unilateral tenderness and swelling, acute shortness of breath, and tachycardia? Pulmonary embolism. What is the next best diagnostic test to order if the pleural fluid is milky? Order pleural fluid triglyceride level. What is the next best diagnostic test to order if the pleural fluid is purulent? Order pleural fluid gram staining culture. What pleural fluid finding is indicative of a hemothorax? Pleural fluid hematocrit level of more than 50% of the peripheral hematocrit level. What is the next best step if hemothorax is identified? Tube thoracostomy. What pleural fluid WBC level suggests peripneumatic effusion? WBC of more than 10,000. What pleural fluid LPBC level suggests empyema? WBC of more than 100,000. What should you consider if the pleural fluid cell count shows a neutrophil predominance, pneumonia, and pulmonary embolism? What should you consider if the pleural fluid cell count shows a lymphocytic predominance, tuberculosis, and cancer? What is the next best diagnostic test to order if tuberculous pleural effusion is suspected? Order adenosine deaminase, which is known to be elevated in TB. What should you consider if the pleural fluid analysis is positive for amylase, pancreatitis, or esophageal rupture? What should you consider if the pleural fluid triglyceride level is more than 110, chylothorax? This type of pleural effusion is associated with bacterial pneumonia. What is it called? Peripneumatic effusion. What is the primary treatment for uncomplicated peripneumatic effusion? IV antibiotics. What is the primary treatment for complicated peripneumatic effusion? Thoracostomy drainage with antibiotics. What are the three common indications for chest tube insertion in a patient with pleural effusion? Empyema, positive pleural effusion culture, and complicated peripneumatic effusion. If a patient presents with pleural effusion on the same side as the lung nodule, and thoracentesis confirms a positive cytology for non-small cell carcinoma, what is the stage of that lung cancer? Stage 4 lung cancer. Thank you all for joining me today in this comprehensive discussion about the approach to pleural effusion. I hope the information presented has been enlightening and instrumental in deepening your understanding of this important topic, which is not only pivotal for clinical practice, but also crucial for your internal medicine MBM exam and Step 2 CK exam preparation. I'd like to remind everyone to subscribe to my YouTube channel, Dr. Palana, where I consistently provide high yield discussions and insights that are essential for excelling in your exams. Thank you and take care.